and welcome to Let's Meet the Virologist, a podcast about the people behind today's virology headlines. People just like you, working to understand viruses and how they affect you. During the COVID-19 pandemic, we are talking with researchers involved in coronavirus and COVID-19 related research so that you can learn who they are and what they do. I am Larissa Thackeray, and I am hosting this podcast from America's Heartland in St. Louis, Missouri. On June 2nd, 2021, we talked with Dr. Ziyad Al-Aly, clinical epidemiologist who studies pharmacoepidemiology, environmental epidemiology, global health, and more recently, short and long-term effects of COVID-19 on health outcomes. Ziyad earned his medical degree from the American University of Beirut, Lebanon, and completed his residency in internal medicine and fellowship in nephrology at St. Louis University before joining the VA St. Louis healthcare system. Ziyad established and directs the VA's Clinical Epidemiology Center and is currently an assistant professor of medicine at Washington University School of Medicine and is chief of the Research and Education Service at the VA. Welcome. Why don't you tell us about yourself?
I am a nephrologist by training, so that's a kidney disease doctor for those of not directly in the medical profession. And I became interested in clinical epidemiology back in residency and fellowship, and clinical research interested me a great deal, and I sort of gravitated toward specializing in clinical epidemiology. When the whole thing sort of broke out, we did have a brainstorming session with my team, and said that what can we do to help out? What do we do, or what can we do to pitch in and do our part in the response to the pandemic? And I myself, I'm a clinician, and I attended on the wards and did my clinical duties. But a lot of my team members are 100% researchers, and so we had this brainstorming session, and we really wanted to do our part. Everybody was pitching in and doing their part. We wanted to do our part, and that's really our that's a sort of genesis of our interest in COVID, and then it became a sort of an exercise of trying to identify what are the questions out there are really important to the public that we could help address in a rigorous way. We sort of started seeing the flood of COVID papers here and there, and variable quality. So we try to focus on things that are on research questions that are really what we think is really important to the general public and important to the policy makers and decision makers, et cetera, and that we could answer with our data. And really the first one was when we realized there was a lot of talk about COVID and the flu, and how does COVID compare to the flu? Is COVID worse than the flu? Is COVID the same as the flu? And there were politicians involved in that discussion. It was on all over this the place, and it was really in the lay vernacular. People were starting to talk about COVID and the flu as a sort of a comparison, and we said that's something we could do. We could actually really delve deeper into it and provide an apples to apples comparative evaluation of COVID and the flu and resolve or address that question and answer it. And that's really our first major work in COVID. And then subsequently from there, sort of me being a nephrologist, we sort of try to do some stuff in the nephrology space. There was, early on, there was a recognition that people with COVID-19 are developing acute kidney injury, or sort of like a, kidney damage as a result of the infection and sort of the other characteristics that sort of accompany the infection itself. And so that sort of led us to sort of be interested in what's happening to the kidneys in people with COVID, et cetera, et cetera, et cetera. And then from there on, sort of it transitioned to really an interest in long COVID.
Before we get there, why don't we take another step back and just ask, so how did you, when you were younger, how did you even think about medicine or this kind of work? How did you get interested in it?
Well, I grew up in Lebanon, and I grew up in a family where actually, my uncle was a doctor, and then sort of I knew early on that I wanted to go into medicine, and went to the American University of Beirut there for undergrad and then medical school. So it was sort of was an interest, was an interest of mine, early on to be in medicine. Obviously, at that point, did not really know that I wanted to be a nephrologist or let alone be a clinical epidemiologist. So those developed along the way, and you sort of see role models around you, and you see different specialties, and you see people doing research, and you see people doing basic research or translational research or clinical trials, and you see those like nerdy mathy statisticians doing models, and that attracts me a great deal. That's sort of like, oh, this is what I want to do, like data work and trying to understand data and build models and trying to understand trends and sort of that to each his own. And that's sort of it may be nerdy to some people and it may be geeky to some people, but that's sort of really how it all came to be. It's sort of the journey through the different phases of life, and seeing what's around you, and sort of is this something that sort of speaks to me? Is this something that sort of really is really it tickles my fancy and speaks to me and drives me and motivates me, and I wake up in the morning like thinking about it and want to do it, and then if people find their ways, and found my way into nephrology and subsequently clinical epidemiology.
And like the clinical epidemiology, was that part of your medical school residency training, or was that something that you sort of developed yourself?
No, it wasn't. And in my view, it's also still fairly underdeveloped. And the medical school curriculum is really barely any meaningful exposure to biostatistics and epidemiology. I mean, there is some, but it's really, in our view, and we're biased because we want people to learn more and do more, it's really rudimentary. And even in residency and fellowship, it's sort of most of the conversation, it starts like, oh, well, this is confounding here. And it starts and stops there. I mean, there's really not a whole lot of really critical thinking and really evolving the idea. And you'll see sort of even up to this day, you see medical students and residents running around and like thinking that actually, intellectually contributing to the discussion and criticizing papers. And it's like, oh, that is confounding, but like, and what's like, how do we evolve that thinking, more? So no, it was later on when I sort of, started, doing clinical research, and then discovering the world of clinical research, and discovering that, oh, there is something called clinical epidemiology, and that's really important. And it's really not only just p-values and confounding. There is a whole lot more a lot more to it. There's causal inference, and there is sort of different fields within clinical epidemiology. There's pharmacoepidemiology, there is environmental epidemiology, there is a lot, I mean, the health metrics, really sort of an amazing field that sort of started about 20 years ago. But how do you really develop health metrics? How do you really, measure burden of disease in a way that could really inform decision making? And those are really amazing, methodologies that really serve to advance our understanding of burden of disease and outcomes. And it's been a joy, honestly. I mean, it's really a wonderful journey.
And I guess for our listeners, can you describe a little bit more when you talk about burden of disease or some of the clinical epidemiology? How does one do these studies, just at a sort of a very basic level?
From a basic level, it's a lot of modeling. So generally, burden of disease is a sort of broad word. I mean, it can be measured in different ways, and there are multiple measures that say, like, there's something called DALY, or disability adjusted life years, and there is sort of years of life loss and years of living with the disease. So those are just generally measures of burden of disease, and to get there is sort of to explain it in simple way, there is obviously sort of like estimation of the risk of certain like an exposure on outcome, and then subsequently sort of an estimation, or like what is from that risk on the absolute scale, what's sort of the burden in a specific population or an underlying population, and so those three things are actually quite informative in sort of understanding the true impact of disease on populations.
And this data or these modeling, they're drawn from what, clinical records or clinical studies, or is it?
So a variety of things. So in our work, we use sort of the electronic health record data, and the GBD work and the global burden of disease study that I'm a formal collaborator of, or formal member of. It's really a meta-regression of a lot of studies, a lot of data banks, throughout the world. It's a global burden of disease. So there's, data banks from the, or studies from the US and obviously from a lot of other places. And actually there are countries where there's no data, and then that's really done through modeling. So the imputation there, or generating the estimates, say for HIV in some places in Africa, because there's paucity of studies, or some studies maybe they're just too small to really be able to give you a big picture of the whole country. It's a lot of mathematical modeling. It's almost like what you do with the weather service, right? Like there's information from variety of sources, and then subsequently sort of modeling to sort of output a picture of what the sort of the disease, let's say for burden of diabetes or kidney disease, looks like nationwide or looks like globally.
And then to follow up on that, can you tell us some of the research you were doing pre-COVID? So before COVID hit, what kind of research were you doing?
Sure. So really, our research program we had a pipeline of research in pharmacoepidemiology. We were very, very, very interested in the competitive effectiveness of medications and also risks of medications. I mean, our group had really contributed substantially to elucidating our understanding of the side effects of PPIs, or proton pump inhibitors, and we were among the first to describe that PPI was associated with kidney disease problems, and PPI associated with early death and cause-specific mortality. So we're very, very interested in trying to leverage data to really study long-term risks of commonly used medications, and sort of PPI or proton pump inhibitors. For those, it's a heartburn medication that people take for heartburn, very commonly used, one of the most commonly used medication in the world, and also in the US. When taken, long enough without indication, can actually be associated with risk of adverse events. So and then recently, we sort of started doing a lot of more work on comparative effectiveness of diabetes medication. But broadly, there was a pipeline of research on pharmacoepidemiology. We're also very, 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 very interested in the health impacts of air pollution on non-communicable diseases and also communicable diseases. So we think that sort of exposure to air pollution is associated with mortality, and we want to understand it better. So we have sort of a pipeline of research, trying to, delve deeper and understand the relationship between air pollution and diabetes, air pollution and kidney disease risk, air pollution and mortality. And that's also was really, really vibrant, pipeline of research. And then the third, pipeline in my group really was this global burden of disease collaboration. Now we contribute to it substantially, and it's been a wonderful collaboration of tons of people throughout the world, generating estimates for pretty much all diseases on Earth, including kidney disease, diabetes, and the stuff that we're interested in and we contribute to. So that was the picture before COVID, and then COVID hit, and then sort of we took a conscious decision, like, do we stay the course and keep doing what we were doing, or do we really roll up our sleeve and pitch in and try to do our part? I mean, as everybody else, try to do our part in solving problems here and contributing as scientists to generating new knowledge and answering questions that are important to the public. And that was sort of the genesis of our pivoting, so to speak, from a pre-pandemic, program that has pretty much like zero infectious diseases, zero virology, and no COVID. And we didn't even know what COVID is. And like, we never worked with viruses, never really, done infectious disease epidemiology. We're more like a chronic disease epidemiology people. I mean, clinical epidemiology is broad, and we sort of, feel like our forte and our major strength is in chronic disease epidemiology. Acute and infectious diseases epidemiology. Obviously, a lot of the underlying science is the same, but it's a little bit of a different animal, and we never really done that. But COVID hit, and it's like, okay, well, now that is here, and we can actually contribute to solving some of those questions or addressing some of those questions.
So I guess, yeah. So with that background, can you tell us a little bit about sort of this latest study where you're kind of looking at once you get COVID, what is your, I guess, risk in a way for adverse outcome, not just death, but in sort of health burden?
Yeah, so that was really, so the early sort of indications that people are not recovering fully after COVID really actually came account early in the pandemic. I do remember reading an op-ed piece in New York Times, early in the pandemic from Fee Lowenstein, an amazing person, and she basically said, let's talk about coronavirus recoveries, and it's not what you think. You don't recover in 2-3 weeks, and you still have lingering fatigue and shortness of breath and et cetera, et cetera. So it was an early indication of like, okay, maybe this is anecdotal, we don't really know. Is this really happening at a large scale? Is this really a thing? So, but it wasn't in the back of my mind. And then, but I followed the story because I was like, okay, that's really interesting. There's something there. So it immediately flagged in my brain back then. And then, Fee Lowenstein's op-ed generated a lot of interest from patients, patient-led research groups, and are absolutely amazing. I actually sort of had a conversation with one of their leaders, a couple of weeks ago, and I told her, "You guys are the Larry Kramer of COVID," and she said, "Oh, this is really a great compliment," and this is how I feel. So they coalesce around each other and really launched this patient-led movement to do research and advocacy around COVID. And I still didn't sort of feel like, okay, is this really a big thing? And then, subsequently it became clearer that these are not like just, 200, 300 people. There's a lot of people who are interested and who are reporting unresolved symptoms, weeks after the infection. I mean, that's really a long time for a virus infection. You get a cold, you're supposed to get better in a few days. You get a flu, you get better in a few weeks. I mean, so weeks down the road to have still, unresolved or lingering symptoms, that's a little bit unusual. So we decided to take a comprehensive look, and really what we did in this paper, we, a lot of people like, well, we didn't have a hypothesis because we didn't know enough to really even formulate a hypothesis. So what we did is what we call like a high dimensional approach to really look comprehensively and systematically at everything that long COVID could result in. And so we sort of built a setup for it and started looking, and wherever we looked, and again, it was a systematic, comprehensive approach, there was evidence of abnormalities. So people with long COVID, people who survived the first 30 days of COVID, these are COVID survivors who didn't really succumb to death in the first 30 days. People who survived long COVID went on to continue to experience fatigue, shortness of breath, cough, so a lot of respiratory symptoms. But not only that, there was really clear evidence of higher risk of stroke, memory problems, higher risk of liver disease, higher risk of kidney injury, higher risk of some GI abnormalities, higher risk of heart problems. There was like myocarditis, new onset heart failure, new onset diabetes. Really alarmingly, also really the mental toll that COVID takes on people. There was really substantially higher risk of new onset anxiety, depression, sleep disorders, and use of antidepressants, anxiolytics, et cetera, et cetera, et cetera. So overall, we think that that beyond the acute illness, COVID survivors are experiencing substantial burden of disease, and it isn't really only respiratory, and it's not really only cough or shortness of breath or fatigue or muscle weakness or muscle pain. There's a lot that is certainly a metabolic signature. We see diabetes, we see clearly a metabolic signature there. There's certainly mental health distress and mental health disorders, and there is really organ involvement, like heart, kidney, liver. So that is very, 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 very clear. And so that was so really, and even when you compare it, so in our paper, so we then said, okay, well, maybe viruses do that, but then maybe nobody paid attention to the flu before, and they cataloged it for a like a more like a longitudinally. So let's do a comparison in that paper, of COVID versus the flu, because we knew. I mean, you're an infectious disease person too, and we knew that some people with flu also still experience a lot of symptoms down the road, right? I mean, like flu isn't exactly benign. Now, comparatively speaking, COVID is worse, but flu is not a good virus either. Like, you definitely want to have your flu shot too. Yeah. But then let's sort of compare COVID versus flu, and even when we compare it versus another respiratory illness that is quite substantial, quite severe, the COVID is associated with higher risk of long-term morbidity and also higher risk of mortality. So we think there's something there around, like, maybe the infection itself, maybe the virus. There's a lot of hypotheses sort of floating around, and I don't want to sort of speculate too much. But it's very clear that COVID survivors, obviously some of them, not all of them, this is not like everybody who really had COVID, but clearly some of them do not fully recover and have lingering symptoms or lingering problems, and those problems can affect, or long COVID can affect, nearly every organ system.
Right. And just to take a step back, so this data was derived from, or this paper in a way was using what sort of a data set? So what kind of clinical records were you using for this?
So we used the U.S. Department of Veterans Affairs national data set to build the cohort and the study data, and that data was developed by the Office of Research and Development at the U.S. Department of Veterans Affairs in D.C. So they have this sort of large COVID data repository. And so we've sort of used that to build our analyses.
I see. And are there some caveats then based on your analysis based on that data set? So for one example, it's going to be more dominated by men, for example. So would you expect that there might be some differences if you had looking more at women, for example?
Certainly. When you do science, you always have to understand like the strengths of your approach, but actually far more importantly, the limitations, like what you know, what you don't know, and also the uncertainty around some of the estimates. So, clearly, electronic health record research is an amazing, we feel it's an amazing resource to really contribute new knowledge, but there are, obvious limitations. It's certainly not another randomized experiment. B, there are maybe issues with generalizability, as you noted. Maybe demographics are different. Sex distribution or distribution of sex, females and males may be different in the general population, and more. I mean, the age differences, et cetera, et cetera, et cetera. But we feel, regardless, I mean, we do feel very strongly that the cohort itself is actually quite big, and when we published it was like the largest study to date on long COVID. And somebody asked me, well, like, oh, well, you only have like 8% female, and then you're like your cohort is 73,000 people. It's like, well, that's actually more than 5,000 females, and that's like, actually, if you only count those, that's still the largest study on long COVID in female, because most of the COVID papers on that, if you look at them, they're like 2,000, 3,000, and 50-50. So they would have like 1,500 female. We have 5,000. So so just because also the huge number and the national that the study is a national study, and it's also like a longitudinal, et cetera, et cetera. So there's a lot of like things that sort of would indicate that the broader message is there. But certainly, I mean, you definitely need to always be cognizant about the limitation of the approach and limitation of the data and limitation of the the study results in general. That makes for always a better science, and understanding like the limitation and not sort of over interpreting things.
Yeah. So what's next? So I think, clearly your study and others are really supporting that there are these long-term effects, maybe not in everyone, but even I think a lot of the studies are suggesting you don't have to have severe COVID, you don't have to be hospitalized to have these long-term effects either. So sort of what's next? What is the next thing that you all are thinking about?
So thinking about long COVID, thinking about a lot about like who is at risk of long COVID. Are there sex differences? I mean, you point. I mean, that's really very, very, very important. Are there age differences? Is like, do the older adults have a higher risk of getting long COVID or higher burden of long COVID than younger folks? Is there a difference based on race? Is it like other racial differences? Black, Asian, Latinx, and white and other racial groups. Are there differences based on race, and also baseline health status? I think that's really quite important to try to, is it the sick people to start with, or sort of the people who get COVID and then don't really quite recover from it, or is there something else going on? And, because COVID is such a complex disease, it's really not one thing, like in our papers, like, at least, I mean, even if you were to reduce the dimensionality of our paper, it would be like 33 sequela. So we call them post-acute sequela, but to avoid like using a lot of specific term, a lot of sort of but those, I mean, there are at least 33 manifestations. I'm going to call them not sequela, manifestations, right? I mean, like it's sort of it's now one thing, and sort of try to gain a better understanding of how these things sort of come together in a phenotype would be what I think is really quite interesting. There is a lot to unpack in long COVID. Also, the metabolic signature we think actually deserves a lot of attention, and there is higher risk of mental health disorders in excess. I mean, people say, well, like, there is a higher, I mean, it's a pandemic, we all suffered, and clearly, there's trauma, there's grief, there is, a lot of chaos, and all of us suffered, and that's true. But what we're saying is that people with COVID suffered more, and as a result, they have a higher risk of depression than other people who did not have COVID, and so I think that also like needs to be, needs sort of like a lot of unpacking there to try to understand what's, better. What long COVID is, how to best define it. Believe it or not, we talk about long COVID or PASC or post-acute sequela, but we don't have a definition. There's no definition for the disease yet. Like, there's no clinically useful definition. And so, we sort of created our own for another paper that we have now under review. But there's really no formal definition. There's like no agreed upon definition of how we even define the disease. So I think we're still in the early stages of really, scratching the tip of or the surface, or like really seeing the tip of the iceberg, but there's really a lot beneath.
Yeah. So I guess turning more personally, why don't you talk a little bit about sort of yourself as a scientist, as a researcher, as a physician, sort of what has been sort of maybe the most exciting thing you've done or the most fulfilling thing you've done in your career? And then conversely, what's been the most difficult thing you've had to overcome?
Oh, wow, that's really an interesting question. So I mean, there are a lot of fulfilling things. I think like the most like really thing that gives me a lot of like rewarding or like a lot of happiness is seeing my mentees grow, is seeing my mentees, like the people that I mentor really grow and publish papers and have first author papers here and here and here and there. And that's really been a joy, sort of seeing them blossom from, junior people who really, struggling to put like a first paper together, and now to have like a really wonderful biosketch. When I like, my favorite moment is when I like get a mentee to send me his biosketch or her biosketch, and then go through the biosketch, say how much we've done together and how much I was able to really, impact this person's life and grow them. And that's really, that's sort of for me, it's really it's really an amazing rewarding experience, and it gives me a lot of joy, and we're not a big team. I don't have like a million mentee, but we're definitely committed, and I'm definitely 100% committed to making sure that they continue to grow and do amazingly well. And honestly, I sort of feel lucky to be working with people like that. I sort of feel just lucky to have wonderful people around me who really want to do real good science and hard workers. Difficult things. I mean, there are a lot of difficulties in life, and there's a lot sort of I came from Lebanon, from a sort of a country. There's a war. I mean, I grew up in the middle of the civil war, so that's one difficulty. I'm a sort of a minority in Lebanon and here, and there's sort of a lot of challenges around that. And in the professional environment, there are, a lot of people who would root for your success and some people who don't and feel, I don't know, I mean, feel sort of unhappy about it. And that's a challenge. But I think in the big scheme of things, you just keep your head above water and keep moving forward. I think life is about perseverance and a lot of it. I mean, a lot of it is also how you rise from a challenge, not really like how you really navigate challenge gracefully and you rise from a challenge. I think everybody is going to fall and everybody is going to fail, and everybody is going to have but those are experiences that sort of teach you to learn better the next time. And if you frame it like that and you persevere through it and you summon the energy to after you fall to get up and I think that's sort of that keeps moving you forward. And I think that's sort of that. I mean, so I try to sort of frame things like that in my life, but there are there are undoubtedly challenges. I mean, I sort of came from a country that was in the middle of war. I couldn't do anything about it except go to the shelter. And I'm in Lebanon. I was a minority, and I was like, okay, so that with all of that, with all sort of like what comes with it in school and bullying and all of that, and then it's not really very different here. So, but I think you just keep moving forward and with grace and perseverance, and I think that's really sort of my so what characterizes my attitude toward this.
And what's been the most exciting thing you've sort of done scientifically?
Scientifically, I think this long COVID thing, I think sort of we really, I think, obviously we've been incredibly lucky to be at the right place at the right time, but I sort of feel that a lot of the things we've been doing over the past 10 years prepared us for this. Like we couldn't do what we did had it not been for a lot of preparation, really blood, sweat, and tears over the past 10 years, really mastering the methodology. We never really knew we were going to study long COVID. We never really knew we want to do this. We never knew we were going to, get a paper in Nature or anything like that. But it was really, a lot of the stuff that we worked on very, very, very hard over the past 10 years that prepared us to like ask the right questions, develop the right methodology to address those questions and address them sufficiently rigorously to really do this. And it was a proud moment. And because I sort of think that it contributes to again, what's most of, so I'm in touch with a lot of patient-led groups and just to see sort of the enormous reaction, from them to this and their gratitude and then like how this is really sort of like, we take it as science, like you're a scientist, like, okay, this is really evidence you evaluate objectively. For them, it's almost like validation of their lived experiences, especially in a world where they're being hit a lot of time by what they call medical gaslighting, by people telling them that, oh, it's all in your head, it's psychosomatic, we don't believe you, no, you don't have pain, you're just lazy, or it's psychosomatic, it's all in your head. And then just incredible gratitude and support from the patient community, and you're doing something right, this is really so I mean, I would say this was certainly a proud moment, and definitely grateful for all the support that we received from all the and even to like some of them are absolutely amazing. I mean, I obviously never really met personally Larry Kramer, but it was inspired by his story of advocacy, and then. Some of the patient-led groups remind me of like how strongly they have the strong conviction and their advocacy with a very strong and clear voice for their own people, for their rights, for their own people as humans to be dignified, for their lived experiences to be recognized as something, and for people to really pay attention to it and devote attention to it, so we can solve it and treat it. And it's really, really amazing. It's absolutely amazing.
Yeah. And then I guess as sort of as an individual, how has the COVID-19 pandemic affected you? So how's it affected your life here? And then I don't know, do you still have family back in Lebanon or no? Okay. So
yeah. So how it affected my life here? Well, for my work doubled. I used to, I go on Twitter sometimes and I like see all these people during the pandemic like baking sourdough bread. It's like I was like my work double. I cannot even I can't barely cook an egg or have time to cook an egg. And you guys are doing sourdough bread. So it's been a challenge, and I think we took a conscious decision that we're gonna double down and try to solve problems, and it's very hard. It's very, very time consuming, and it's very resource intensive, from time and effort and brain energy. So we literally the workload has substantially increased, not decreased, as a result of this pandemic, and on a personal level, there's a lot of stress and a lot of uncertainty. And honestly, sort of reduced social contact and isolation and all that. So that's really affected me personally, I think, negatively. I'm pretty sure this is I'm saying this is my experience, but I'm also certain that it's shared by a lot of people. It's sort of we all went through a pandemic together. This was a big deal, and to some extent, pretty much all of us are in some way or another scarred by it, and probably for a long time, if not permanently. It's something that happened to all of us, and it's profoundly impactful on people's lives, and including mine. So yeah, but we found, we felt through it all throughout the moment of isolation that the best way to respond is to really work more and work harder and try to solve problems.
And then I guess early on in the podcast, I was sort of asking people, how would you talk about risk of COVID? But I think what's now important is sort of how do you think about and how do you talk with family and friends about sort of vaccination and sort of the advantages, the disadvantages to vaccination?
Well, maybe for the most part, I would be preaching to the choir, but generally speaking, that I sort of feel like COVID itself is a horrible disease, and even if people who survive COVID, and even if the people, and some people, as you noted in our studies and others, and even the people who have very mild COVID, they could actually still have long COVID and can have really miserable consequences from long COVID. And if you go back and see that acute illness, it's like they had a mild acute illness, just like a little fever for a few days and a little cough here and there, and shortness of breath, and all went away, but they couldn't recover their energy, or they had memory problems. They had myocarditis 3, 4, 5, 6 weeks down the road. So, how did that happen? We still don't really know, but it's very clear that even mild illness in young people can result in long COVID. So COVID is a really a serious disease. Long COVID is a very, very serious disease. The best way to avoid all of that is to get vaccinated. So I think generally I would be preaching in my choir to the choir in my circle, circles, but to us, the answer is very, very clear: vaccinate, and that requires community engagement, requires engagement by every sector in society, and hopefully the vaccination rates continue to go up. We are in a country where we're blessed to have abundant and available vaccines, and really the best way to save us is to really get vaccinated, and so I hope that message resonates with people. But this is very, very important. Again, for we study long COVID, the best way to avoid long COVID is to avoid COVID through vaccination, period.
Yeah. And what are your thoughts about vaccination in the pediatric population? So just as a aside, I personally, my kids have now started to get vaccinated. So one is just got, is getting his second shot, and my 12-year-old will have his first shot in about 2 weeks. But I know that there's some more hesitancy in a lot of groups about whether that is a good idea, and I just wanted to get your thoughts.
We also think it's a very good idea. I mean, again, COVID is a horrible disease, and certainly can happen in children, can certainly happen in young people, certainly can happen in children, and also long-term or downstream ramifications of COVID or viral illness can also manifest in children and can be incapacitating. Again, this is really would be rare, but it can be in children. But it can also be incapacitating. So what we know about the vaccine, well, let's start with the objective data. What we know about the vaccine, they're incredibly safe and very effective. I mean, when they started doing the trial, like I thought, maybe we'll get 70%, efficacy, 75% efficacy, 95%. I mean, are you kidding me? And the side effect profile, I mean, so they're incredibly effective and really safe and in our view, there really should be no reason for. I mean, we understand why some people are hesitant, but really we feel very strongly that the best way to get us out of this is and to get us as close back to normal as possible is to vaccinate. And by the way, COVID isn't going anywhere. So you cannot wait it out. You're not gonna say, oh, I'm just gonna not get vaccinated and maybe I'll just go away in a year or two. It's not going away. And COVID is likely will probably stay with us for 100 years. I mean, this is not something that's going to go away. That's it. I mean, it's a much smarter virus than MERS and other things. So this is not something that's going to disappear. We're going to have to live with it. Now, the good news is that more and more people are getting vaccinated, but we really definitely need to work on the segment of the population that are so far hesitant, trying to understand why and try to sort of work with that to really try to optimize those rates in all population groups, not only high-risk population, and also include children.
Right. Well, we're coming to the close. Thank you very much.
Thank you very much.
Ziyad's work over the past 10 years developing the methodology to study the effects of medications and air pollution on health, as well as the global burden of kidney disease and diabetes, allowed his lab to pivot last year to study the substantial systemic burden of disease associated with long COVID. Current work in his lab continues to determine how to define long COVID and the risk factors associated with developing this disease. This has been Let's Meet the Virologists, a podcast about people who study viruses. This is your host, Larissa Thackeray, and thanks for listening. You can find us on Google, Apple, Amazon Music, Spotify, and other podcasts, or at lmtv.podbean.com.